And we are live. This is a with my sixth episode, I think, and I'm here with Dr. Peter Pfeiffer. Did I say that right? Pfeiffer?
Yes, perfectly.
Five dog. Tell us who you are, what you do. I know you're an anesthesiologist by trade, right? That's what you do.
That's right. Yep. And I've been practicing 20 years, a little over that. Dental and oral surgery only for 12 years out of that.
You're an MD though, right? You're not a dental anesthesiologist. You went through medical school and you said, "Oh, anesthesia is so cool. I'm going to go on and do that." Is that
Correct.
kind of how it went?
That's right.
Really?
Landed actually almost by accident practicing anesthesia, and it wound up being a perfect fit for me. Temperament-wise, skill set-wise, everything. It was right for me.
So what are we talking about today? All right. So we are talking about a couple things. Actually, we're going to start off, I think, with redheads. Redheads in anesthesia, redheads in dentistry, basically. It's a thing, if you don't know, and if you're a redhead, you may or may not know. But there are some anesthesia issues with local anesthesia and or even moderate sedation, which I do in the office. I do IV sedations. And then obviously you do general anesthesia quite a bit. The other thing is weed, marijuana, and dentistry. Local anesthesia, IV sedation, general anesthesia. So these things are prevalent now, more so now that it's become legal at a state level in many states. And so we're seeing more and more of these issues pop up. So without ado, let's get into it.
Okay. Here we go. Fire away. So my experience, redhead experience, redheads are rare, actually. 2 out of 100, right? That's the number that people
like 2%.
recognize. Right.
Yeah.
And that number is worldwide. And so if you eliminate China and Asia, you're eliminating a lot of people, and you're making it higher than 2 in 100, right? I don't know what that number is.
I see what you did there.
But it's definitely higher, right?
Right.
And so this is not a trivial concern. One of the other aspects of that is that redheads, they have a different way of experiencing pain. And so cold temperatures, they will notice more, but it hurts less, which is kind of an interesting thing.
Yeah.
I would say.
Yeah, definitely. I've read that too. Like they perceive cold more so. They're harder to sedate or get numb in the office. So I've heard stories from patients like, yeah, I can't get numb, and oftentimes the dentist will try to do the procedure. They'll send them to me, and and it says on the referral, couldn't get patient numb. Patient wants sedation, and so I'm like, oh, okay. So redhead wants sedation, and then I'll schedule them for a sedation, and yeah, they're taking more medications. They're taking more propofol. They're taking more midazolam, fentanyl, everything, right? And sometimes you give them all what you normally give, and they're just looking at you like you didn't even do anything. And you're like, okay, well, let me give them some more. Anesthesia is not a button you can press. It's people think, oh, it's supposed to be asleep. I'm like, well, we're doing conscious sedation. We're doing moderate to sedation in the office. We're not putting a breathing tube in for these cases. And so like everyone is a little bit different. There's no button we press to make people sleepy. Meds get titrated in as they're needed. And some people, they just have a narrow window where the pulse, the heart rate, the saturation, oxygen saturation, the blood pressure, and their overall, level of sedation is at a good window to do the case. One thing gets out of whack, like your heart rate's in the 140s, 150s and up, that's a problem. You got to manage that. Yeah, so that we see that quite often. We hear that from patients. Like, I just can't get numb. It hurts, or it wears off super quick. They metabolize it really fast.
That's right.
Right. That's a really common thing.
So there's a point in there that I think needs a little bit of digging, right? So we always differentiate between anesthesia and analgesia, right? Taking away pain. And so on the consciousness aspect of things, redheads are higher. On the pain aspect of things, not only are reds often lower on that scale, but they also respond to opioids more than non-redheads.
Right.
right? And so since the Korean War, more or less, I'm going to go out in the weeds here, back in time, we have done what is called a multimodal technique of anesthesia. That is inhalational agents, IV agents, oral agents, local, for example, which I'll talk about next here. All of those things combine to create anesthesia. Anesthesia isn't a thing that you give to a patient. It is a state in that patient after all the medicines are on board, right? Anesthesia, right, which is consciousness, is harder. Pain management, though, is easier. And local anesthetic doesn't work as well.
Right.
So
That's weird because local anesthesia, when you read about what it is, it's you're blocking sodium ions from getting in and out of, where they need to be. But then you think about people with red hair, it really has to do with a gene mutation, right? But that's anywhere not near a peripheral nerve. So we don't know. I don't think we know why that happens, right?
yeah, I agree. A paradigm of agonist antagonist with opioids, and one of the hormones that is made by these abnormal melanocytes in the redheads.
Right.
And so when they're having that tug of war, in them it balances one way, and in the non-redhead it balances another way.
Right.
Whether we understand all of that and how all of that works, I don't know the answer to that.
Yeah, because people quote this study. There's this 2004 study, and then the same group did one in 2005, and that's where they get that 20% more anesthesia number. Like they found that the redheads required 19% more desflurane or inhalational anesthetic in these cases, and so kind of people just round up to 20, and I've seen it written as 20%, and so they kind of quote from these papers, and so you're right, they need more medication to get that level of sedation or local anesthetic. And then, but when you do the surgery and you give them some pain medication afterwards, they generally need less of it. So that's really interesting.
That is my experience, certainly. Yeah.
Yeah. So yeah, their pain tolerance after the fact is better, but during the case, it sucks.
Yeah.
So like their threshold is lower for that. So still very interesting to me.
Dr. Wahan, when you're doing sedation in the office, whether it's light, moderate, deep sedation, whatever it is, most of what you're providing for the patient is analgesia and amnesia, right? They don't remember and they don't hurt, right? But what I do when I'm in any office, your office in this example, we make patients unconscious, and that pain element of that is part of it, but it's more background noise than it is the main event.
Right.
When we're doing what we do,
Right.
putting a patient all the way under anesthesia.
Right. So for you guys getting the patient, and we're talking to you today because you work with a lot of dentists. Like you go to different offices. You're working with a pediatric dentist maybe one day, an oral surgeon, a periodontist, a general practitioner, a GP dentist, essentially. So you've seen a lot of offices and things, and basically, so these dentists are working with you. They're seeing patients fully under and working on them with you. You're providing the anesthesia for their case, and so a lot of these things are issues. So, for you a little bit, you maybe use a lot more propofol. You give them your normal induction dose of propofol to get the endotracheal tube in, and they still need more. Or you give them a whole bunch, and then they start coughing during the case. They're kind of not all the way out. You need to give them more. So those are things that we see, when they're under completely. Patients don't obviously remember those things, but that stuff still happens, right? Even when patients are completely out, like in the operating room. They're going to cough. They're going to do these things, and we call it bucking or whatever, but they're coughing. They're still reacting in a way. And so that's also a level of, hey, we need to increase the anesthesia. We need to do this. Or you're seeing vital signs changes. Like, maybe the local anesthesia the dentist gave or I gave is not enough. We need to give some more. And that'll also make them more comfortable. Because a lot of these patients are consciously breathing on their own after a period of time, right? You're ventilating them, but when they don't need it, they don't need it. You're supporting their airway.
Correct.
but they don't necessarily need mechanical ventilation, for these cases for the whole duration of the case. You're not paralyzing them,
Right.
typically in the dental office. So, yeah, so you see it at a different level. We see it when we work with you at that level. And then when I'm treating the patients, I start the IV, I give them the midazolam versus propofol, ketamine, all the things. And I'm finding in my 17 years of practice, I'm seeing a lot more patients. And when I say a lot more, I would say every month now I'm seeing patients like this that I find, even for me, they're harder to sedate. I'm like, you know what? I'm getting too old. I'm not going to ride this rodeo. Let's just book them with Dr. Pfeiffer. I'm seeing a lot more of those patients, and red hair. Now we're talking about marijuana here in a little bit. That's a lot more prevalent. And so these are all things that interfere with local anesthesia and level of sedation, because sometimes, even as we jump into marijuana a little bit, the anxiety level of patients may be higher. Patients that are 16, 17 years old now or are raised differently than they were when I was 16 and 17. I think every generation kind of does that. They're like, yeah, kids nowadays aren't so tough. Maybe it's true, right? Because I think I see more of that too, where there's the helicopter parent or something like that just, they can't have pain, they can't have pills. You got to put them on liquid medication. They just can't swallow a pill, and they're, almost 20. So we see a lot more of this kind of stuff. So I'm seeing a lot more patients that I'm having trouble even to do IV sedation on. And then I'm like, you know what? Thank goodness we have someone like you who can come to the office and do these cases and really keep the patients really super comfortable. But again, that's more and more that we're seeing. And that's why this is a business for you now, because you're seeing these cases.
Right.
And dentists are doing bigger cases. They want a deeper level of sedation for their patients. So that makes a lot of sense.
Yeah. And all of these things are happening in the context of what is happening overall in healthcare, which is that hospital cases being done in the hospital, they will have much, much higher cost. And it might actually price a patient out of having certain operations in the hospital. And
all the red tape you have to go through to get into the hospital, with all the
pre-op
testing, all the visits to your doctor, the history and physical, everything you need to have a surgery done in a hospital is quite a bit now.
Yeah.
You coming to a dental office or an oral surgery office now is super convenient for the patient. Yeah, the cost is going to be a little bit more, but you're also paying for, you're getting in and out of there. You're not going to a hospital. You're not waiting in their waiting room and doing all those things that you normally wouldn't, take in half your day or most of your day, to get in and out of there. So there's pros and cons to this, and we're super happy that we have a group like you guys to lean on when these patients come through. And now I'm seeing more and more that are just more difficult to get numb, more difficult to sedate. Why don't we just jump into the weed?
Sure.
Figuratively,
out in the weeds.
Figuratively, that's a buttermilk biscuit. Here we go. But yeah,
so we live in Washington State, which was one of the earliest legal recreational.
It's for my glaucoma. I use it
states.
for my glaucoma.
Right. I know you do. And so I think people in Washington, people in Colorado, right? And
I guess California now, right?
Places, yes.
Oregon,
places
obviously,
where it's been
state legal,
unenthusiastically enforced as well, right? I mean, it's almost legal in those
weird.
places.
So yeah, so it's legal in a lot of, marijuana is legal in a lot of states. Okay, that's fine. Mm-hmm. But technically, it's still illegal
like half,
federally.
Actually,
yeah, I know, it's a lot. Yeah. And then but it's technically illegal federally. So the issue with that is there's not a lot of studies on it because it's illegal federally. Like, who's going to do these marijuana studies, And I was reading into this. I don't know if you saw this. The only marijuana studies that are kind of approved that people can do, there's this lab in, was it Mississippi or something, that people get the federal studies can get their weed from. Okay. And there's problems with that because it's only potent up to 16% or something, but the stuff people are using on the street are like 35%, 36%. So it's not even accurate as far as, the potency of it. So that you can do some studies, but you have to go through the government to get your weed from this one place in the country. So it's still really difficult. So it's really hard to study this stuff because it's illegal federally. And so all of this stuff is anecdotal, or you can see case reports or little minor things here and there, but it's really still hard, I think, in my opinion, to study.
Yeah, it is hard definitely. And
A lot of self-reporting, you know, all
it'll
that kind
get
of stuff.
easier now that it's legalized on this state level in a lot of places, but all those studies are going to be retrospective, right? Because
Right.
otherwise it would never get past an IRB and all that kind of stuff. But there was one recently that I looked up, which was this year, and they measured post-operative pain scores and post-operative oral opioid use in older people, like older than you and I.
Oh, okay.
Yeah. And regular cannabis users versus not. And it was clear in that data there that cannabis users had higher pain scores and they needed more post-operative opioids.
Yeah, and there was a study done in our journal, the Journal of Oral Maxillofacial Surgery, in 2023, and they found that, you know, for IV sedations, you know, they found that cannabis users needed more midazolam, fentanyl, ketamine, and propofol. Those are all the things that I use, right? Pretty much most oral surgeons can use those things. So there was a recent study that did find that to be a thing, and that was just about a year ago that one came out. Here's the thing about weed: we're seeing a lot of kids. I would say kids, but you know, they're teens, right? They're younger than 18. A lot of times they're coming in for consultations with their parents, and so they have to fill out a health history with their parents around. They get it in the consult room, kind of with one of the parents or both of them, and so most of them now are not putting, you know, I smoke weed on their health histories because they're coming to their consultations with their parents. They don't want to put it on there, you know? And so I don't even know half the time that the kid is a user or uses it quite frequently or infrequently. I don't know, until sometimes we get into the sedation. Now they're showing up for surgery and they're tachycardic in the 140s, you know? And what did the studies say? Like, even when you smoke 3 days ago, you could still have tachycardia from that because it clears so slowly, right? So if you don't know this, so marijuana is highly liposoluble, right? So it's stored in the fat cells more so. And so even when you stop smoking or however you're taking it, it's still in your system for a while, right? And I saw one study that said you can even still have tachycardia from it from like a couple days ago. You know, tachycardia, increase in heart rate. I'm seeing a lot more tachycardia in IV sedation patients. And sometimes, you know, when they're in the room, they're on some medication, you can ask them if they're still awake enough to answer. And a lot of them will tell you, yeah, I smoke weed, don't tell my parents. You know, they'll say things like that. I'm like, yeah, I figured, you know, we can't get you asleep. And your heart rate's pretty high still, you know? And so, yeah, I'm seeing a lot more of these cases. And so I think it has a lot to do with that.
And
tachycardia
also
is
over the
biggest
past
issue.
20 years, maybe, potency of the marijuana on the street has gone up double, triple, 5 times, depending on the period of time that you're looking at that. It's been going up year over year, making that problem even harder.
Yeah. And then this other study that I said, so people that use marijuana, let's say maybe once or twice a week, you know, they qualify as like low dose users. The first hour after you smoke or however you take it is the riskiest hour for your risk of MI or heart attack, right? It's like a 5-time fold increase that first hour after you smoke weed, let's say, versus cocaine, where I think it's a 24 times, you know, like you do some coke, you're 24 times more likely to have a cardiac event. Despise the stats. Marijuana, 5 times more likely in that first hour of use. And what I find is weird. So there's this thing called cannabis withdrawal syndrome. So if people that smoke weed or use it every day or almost every day, right, and you tell them to stop before surgery for a couple days, for whatever your protocol is, let's just say it's a 3-day protocol or 5 days. What if they go into withdrawals and then it's even worse? You know, like it's still really backwards. But then when they use it and they stop for 3 days, it could still be in their system.
Right.
They could still have tachycardia, or they could be in withdrawal from not using it.
Yeah.
If they're a chronic user, right?
The other end of that also is post-operative nausea and vomiting. Goes up, right? A lot.
Yeah.
Yeah. And so I actually don't know that it's obvious at this point that we would want them stopping more than, say, 24 hours in advance
Yeah.
of the surgery. I don't know.
Yeah, that's what I was
I don't
thinking,
know if
because
anybody knows that.
then you're hitting the people that are possibly going into withdrawal. If they're ingesting it that much, and that could be a bigger issue. I mean, obviously it's not alcohol, but people go into alcohol withdrawals fairly quickly if they're, without it for a few days even.
Right.
And those are pretty serious, right? You can have seizures, you can have all sorts of
they
things,
can be
right?
fatal.
I mean,
Certainly.
I remember in the hospital when I was a resident, you have an alcoholic trauma patient and you're prescribing them beers on the floor. Like, give them 2 beers a day.
Right.
That was a thing. You write in their
Ativan.
Yeah, and even beer. Like, we even gave them beer. I'm like, here, you need to give them 2
That's
beers
funny.
a day while they're in the hospital, just so they don't go in the DTs, and that was a thing, right? So, yeah, so that's the biggest thing. And the other issue is the airway, right? So marijuana, obviously, it's like, you're inhaling it. Yeah, for the most people, they're inhaling it, but you can take it different ways. Airway hyperreactivity is a big deal, especially with IV sedation in the office. Like, you're getting your wisdom teeth out, you're coughing. When you cough enough, you might get a spasm, like a laryngospasm. Those are all airway emergencies that, in IV sedation land, we don't like those. You don't mind them as much because you're used to them and you can always throw a tube in.
Right.
But, we're doing these IV sedations not with a breathing tube, right? We have all the stuff if we need it, but we don't do those things on a routine basis like you do. Right. So even for us to put that in, once every 20 years, it's not the same.
No, it's not.
In that scenario.
People have asked me that before, a little bit different topic, but people have asked me, all right, I intubated during residency. I did 5 a day for 2 years, and it's like riding a bike. I don't think it's like riding a bike. I think it's like speaking a foreign language. I think
agree with
you have to use it in order to, it's a perishable skill, basically. And so I think that
it's not the same
screening
anymore.
patients in that way and trying to figure out whether or not you want me there managing it or whether or not you want to keep them lighter. But, you have a self-selecting population very often. Usually the chronic daily marijuana users are on the anxious end of that spectrum anyway, right? Sure. And so it feeds on itself.
What's funny is people say, hey, it helps with my anxiety. But there's also a lot of studies now that's saying it actually promotes anxiety and can cause psychosis.
Yeah.
And so people say that it helps with my anxiety because when you use it, depending on which version you're taking, you feel more mellow, let's say, right? But really, your heart rate's up also. And so it's hard to be mellow when your heart rate's in the 130s.
Yeah.
Those things don't make sense together. So you may feel mellow, but you're tachycardic, and you use it enough times, it can actually promote anxiety. So those are two things that conflict, with each other. And what it really boils down to is when I see these patients come in and they have a history of marijuana, I have a hard time now, and this is more prevalent, 17 years in of doing these cases because weed has been legal now for 10 years. So now these kids are in their teens and above, right, that have been using it for quite a while probably. And they're in 20-somethings and so forth. So I see it. I find patients are harder to get relaxed, get their heart rate down, get them asleep enough to even do the procedure. I find that stimulation, for me, let's say I give them the propofol, some ketamine, some fentanyl, and some midazolam, which is a lot of things. Right. Anesthesia is like a cocktail. It's like a lot of different things. No one gets the same dose, really. It's just whatever it takes to get that level of sedation. And I pull their cheek back to look in. Now that causes their heart rate to go up, and now there's a tear coming in their eye. Even though they're sedated, just a little stimulus sometimes that's perceived in a different way can cause that reaction.
Yeah,
and so now you
everything
have to
is sort of amped up.
It is. Yeah. And you have that little narrow window. The sound of the drill, while it's not hurting you, the noise of it also can be a stimulant for them.
I'll tell you what, I'm in the office all day, every day. I don't even like that drill.
I mean, seriously. Yeah. I mean, it's better than those old hall drills we used to use. It's you ever seen those? With the big rope on them, with the nitrogen, the powered nitrogen.
Oh my gosh.
And I'm like, hey, you can hear a little bit of noise and you push that hall drill. It's like, Like I'm even shaking,
That's
like my
funny.
legs are shaking, like it's vibrating so much. We don't have those anymore. We have electric drills now. But again, it's still, it's high torque. So yeah, so with weed, like I said, we're seeing a lot more cases that we're having to refer out to the anesthesiologist now. I think they're just for patient comfort and safety. And patients get mad. Like they're like, "Ah, I thought, I was going to be asleep for the procedure," and you tell them, what, I don't want to start the procedure because it's really difficult to get you to that level of sedation where you need to be. But a lot of times what I'm finding is I think it's hard for patients to take responsibility also in their choices to use it or use a bunch of tobacco when they have a lot of post-op pain and so the nicotine's in your system for weeks or whatever. So I think it's difficult a lot of times for patients to kind of own up to it. Yeah, they don't really understand it. From there, yeah, it just makes me mellow, but they don't understand the physiology of what it does to how we're competing for the receptors and all those things. So yeah, I think it's really interesting. It's evolving, and like you said, it's hopefully more studies are going to come out about it. But yeah, the main thing I'm finding is, our office protocol, and you go to all these meetings like, you need to have them stop for like 4 days, 5 days, people are saying. But then, you read the stuff on the withdrawal for these people are like, well, you're hitting their withdrawal time. Now,
Right.
is it better for them or worse for them?
Well, and you haven't even touched on the biggest hole in that theory, which is compliance.
Oh, yeah.
You take a daily marijuana user for 10 years, 20 years,
Right. Yeah.
whatever it is, and you say, I need you to stop for 5 days.
Right.
Okay, doc. Sure. Yeah, it just doesn't happen.
Yeah.
And so
I know. You don't
one
even
of the,
know if that's
the
true.
for
Right.
that period of time.
And maybe you don't even want them to do it because of the withdrawal.
Well, that's true.
So
right?
I'm reading
Which
this
is
right
another
here.
aspect of that question, certainly.
Yeah, this right here. This is cannabis withdrawal syndrome. The signs and symptoms: irritability, right? Anxiety, depression, mood issues, insomnia, you can't sleep, tremors, okay? So the onset can be less than a day for high dose chronic users of withdrawal. So you tell them you can't smoke weed for 3 days, like 2 days, 1 day even, you can get into this. The duration of this can be a couple weeks if they stop. It's a long thing to withdraw from this. So yeah, it's a deal. And so I don't think we fully understand that part of it either. And so our protocols really don't make sense in a lot of ways.
Right.
It's evolving, I guess.
Evolving.
Yeah.
That's a good way of characterizing it, I think.
Yeah. So, there's studies that said, marijuana users obviously require more propofol. They require more sedatives and very similar to redheads in a way. So yeah, this is kind of what we're talking about. These patient populations we're seeing more of, and I mean, the red hair is there. The weed, what about the red-haired person who smokes weed every day?
I was hoping that you would
just
ask
send them
that.
all to you. I don't even do the consult. I'm like, you know what? I'm going to schedule this with Dr. Pfeiffer. Is that where we're going to?
That'd be great. I would like
yeah.
that.
So he's like, the patient's like, what did I do? Nothing. But yeah, this has been great. I'd like to have you back on if you're up for it at some point.
Thank you. Always up
to
for it.
Talk about more stuff. I mean, I think we can. There's so many topics that we could branch out to. But I thank you for coming on, and I'm just gonna give you one more. Here we go. You even know who that is?
No, I don't know who that is.
Sir Mix-a-Lot.
Oh, okay. Well, he's a local boy,
The
right?
90s rapper from Seattle.
Yeah. So thank you
Oh, you're
for
welcome.
inviting me, and I appreciate the topic idea, and we've got lots of others that we were sort of
Yeah.
texting each other.
If you
back
guys
and
listening,
forth,
all the
and
10
so-
people listening, if you guys have any ideas, shoot them to me, and we can figure them out as well. So all the time.
And I would
out
imagine
there.
that Dr. Wahan will put my contact info in there and
Yeah, it'll be
all
up.
that jazz.
It'll be up somewhere. All right, later, man.
Thank you. Bye-bye.
Bye.